Good morning. My topic of presentation is venous obstructive disease of the retina. The content of presentation are central retinal vein occlusion, hemiretinal vein occlusion, branch retinal vein occlusion, combined CRO and CRVO, and combined BRO and BRVO. Introduction. Venous occlusive disease of the retina is the second most common retinal vascular disorder after diabetic retinopathy. Retinal venous occlusion comprises of condition caused due to blockade of small or large caliber vessels which are carrying blood away from the retina. It is classified according to the anatomical level of occlusion into three distinct entities, which are central retinal vein occlusion, in which the occlusion of the central retinal vein at the level of or posterior to the lamina cribrosa. Branch retinal vein occlusion, there will be occlusion of tributary veins, typically at the site of an arteriovenous crossing. Hemiretinal vein occlusion, occlusion at the disc involving either the superior or inferior hemiretina. Pathophysiological mechanism due to virtual striate, which is comprises of vessel wall injury, hypercoagulability, and stasis. Pathophysiological mechanism is compression of central retinal vein by rigid lamina cribrosa, elevated IOP, or adjacent atherosclerotic artery, which lead to set of virchow striate, which lead to activation of coagulation cascade and formation of thrombosis within the vein, which lead to venous outflow obstruction and increases venous pressure, which causes retinal capillary congestion and leakage, and retinal hypoxia and ischemia, which lead to release of VEGF and inflammatory mediator, which causes macular edema, neovascular glaucoma, and CRVO. Etiology and risk factors are: it occurs in patient more than 50 years of age. 90% of patients are more than 50 years of age. Hypertension, diabetes, hyperlipidemia, smoking, hypercoagulability, hypothyroidism, systemic inflammatory disorder, open angle glaucoma, hypermetropia, and female on OCP. The uncommon predisposition are seen under the age of 50 years, which are myeloproliferative disorder comprises of polycythemia, myeloma, acquired hypercoagulable state include prothrombin gene mutation, factor 12 deficiency, hyperhomocystinemia, lupus and APLA antibodies. Inherited coagulable state include activated protein C resistance, protein C and S deficiency, and antithrombin deficiency. Inflammatory disease associated with occlusive periphlebotitis are Behçet syndrome, sarcoidosis, Wegener granulomatosis. Systemic assessment. All patients must undergo following systemic assessment to reveal the underlying systemic association, which are blood pressure, ESR, CBC, RBS, lipid profile, plasma protein electrophoresis, renal function test, thyroid function test, and ECG. Investigation to be ordered in patient younger than 50 years or having his family history of thrombosis, or himself or having past history of thrombosis or bilateral retinal vein occlusion, and when etiology factor cannot be found, which are chest x-ray, CRP, thrombophilia screening, PT, APTT, protein C and S, and anticardiolipin antibody, and autoantibodies, RA factor, antinuclear antibody, anti-DNA antibody should be done. ACE level, homocysteine level, VDR, RPR, and carotid Doppler should also be done. Central retinal vein occlusion is because due to a central retinal vein and artery possess a common sheath at the crossing points posterior to the lamina cribrosa, so that the atherosclerotic changes of the artery may precipitate central retinal vein occlusion. When occlusion occurs, it will result into retinal hypoxia damage and lead to VEGF formation. Patient present with symptoms of sudden and painless vision loss, presenting with visual acuity of 20/40 to hand motion, may also present with transient obscuration of vision. Anterior segment evaluation should be done. Undilated slit examination to rule out neovascularization of iris or angle. Pupillary reaction should always be noted, and intraocular pressure must be recorded at each follow visit due to risk of neovascular glaucoma. Fundus finding: there will be presentation of dilatation and tortuosity of entire venous segment with flame-shaped hemorrhages, dot and blot hemorrhages, and present in all four quadrants, giving a blood and thunder or splash tomato appearance. Macular edema will be present, cotton wool spot will be present, splinter hemorrhages and optic disc swelling will be present. Vitreous hemorrhage may be present to a variable extent. Optociliary shunts are also present, and NVI and NVA, NVD or NV can also develop. Investigation: fluorescein angiography shows variable delayed venous filling and staining of blood vessels. Hyperfluorescence due to capillary non-perfusion area, and macular changes are, that is, patelloid leakage in macular edema. OCT will allows quantification of the severity of macular edema, and it is a useful way of monitoring its course or the response to the treatment. CRV involving the fovea shows a small subfoveal retinal detachment comprising of outer retinal spongy edema, and the most important feature is increased hyperreflectivity of the inner retinal layers and obscuring the visibility of outer retina. Optical coherence tomography shows enlarged foveal avascular zone and parafoveal capillary non-perfusion. Macular edema shows areas of altered inner plexus and absent deep vascular plexus. Electroretinogram shows reduced A wave amplitude and prolonged A and V wave implicit time. Then there are two types of CRV, which are non-ischemic CRV and ischemic CRV. Non-ischemic CRV, the occlusion occurs behind the lamina cribrosa, that is 6 mm behind the lamina cribrosa. It is also known as venous stasis retinopathy, and it is seen in 80% of cases. It is present as rapid monoocular painless diminution of vision better than 6/60 without any RAPD. Mild dilatation of veins with few dot as well as flame-shade hemorrhages in all four quadrants. FFA usually demonstrate prolongation of the retinal circulation time with minimal area of non-perfusion, that is less than 10 days diameter of capillary non-perfusion area, and ERG is nearly normal. In ischemic CRVO, the occlusion occurs just at the lamina cribrosa region. Presented with unilateral sudden painless profound loss of vision, the vision is usually worse than 6/60. Here RAPD is present and fundus shows marked venous dilatation with and tortuosity, widespread superficial and flame-shaped hemorrhages, and present in all four quadrants. There will be presence of multiple cotton wool spots are seen because of non-perfusion, and macula is markedly edematous. Disc edema is usually present. FFA shows capillary non-perfusion areas of more than 10 disc diameter. And the ERG shows reduced B wave amplitude and reduced B is to A ratio. Course, the acute feature usually resolve within 6 to 12 months and may be replaced by exudate, venous sheathing and sclerosis peripheral to the site of occlusion and variable residual hemorrhages. Collateral will be present as a retinal hemorrhage resolve with time. RP alteration will be seen, and duration of resolution varies according with the extent of hemorrhage. Although macular hemorrhage may persist, and epiretinal membrane formation may follow. Complication, there will be presence of chronic macular edema and neovascularization. Anterior segment neovascularization, which in turn of iris or angle, vitreous hemorrhage and epiretinal membrane also develop. Impending central retinal vein occlusion. It occurs in younger patient and present with no symptom or consists of only minor or transient blurring that is characteristically worse on waking up. On examination, there is mild retinal venous dilatation and tortuosity with relative and few scattered dot and blot hemorrhages. The mainstay of treatment is correcting any predisposing systemic condition. The treatment consists of medical therapy, laser therapy, intravitreal anti-VEGF drug, intravitreal steroid, and surgical therapy. Medical treatment. After thorough examination, evaluation of the cause of CRVO, therapy directed towards the primary systemic or ocular pathology to be started. For systemic hypertension, hypercoagulable states, and raised IOP, the particular therapy is started. This is necessary not only as treatment of primary disease but as a prophylaxis for the prevention of similar disorder in the fellow eye. Secondary therapy treatment. These therapy are mainly directed to deal with the sequelae of CRVO, particularly macular edema and neovascularization. Neovascularization occur in eyes with CRVO within a span of first 3 months after the vein occlusion, leading to neovascular glaucoma, popularly described as 100 days glaucoma. The main goals of treatment are to minimize macular edema, maintain central visual acuity, and reduces the risk of vitreous hemorrhage and prevent neovascular glaucoma. Treatment of macular edema are given by following studies, which are observation by CVOS, corticosteroid therapy by SCORE study, dexamethasone implant study by Geneva study, intravitreal anti-VEGF therapy by Cruz, Copernicus, Galileo, and Tenzite study. According to CVOS criteria, if visual acuity at 3 years to be measured, Then green macular lesion, and one arm was observed, and the result was laser reduced angiographic macular edema but did not improve visual acuity. So in cases of CVOS, we started on observation. Incidence of anterior segment neovascularization, prompt PRP, and PRP deferred until appearance of NVI or NBA. PRP is recommended when at least 2 clock hours of NVI and any degree of NVA is observed. Score study, in which the it is divided into 1 mg intravitreal triamcinolone acetate 4 monthly, 4 mg, and observation. And outcome was measured as gain in more than 15 letter. And the intravitreal steroids are more likely to produce gain in visual acuity, but the side effects are more like cataract formation and elevated IOP. Then Geneva, which is Ozurdex dexamethasone implant study, consists of one arm was given a single 0.7 mg implant, other arm was given 0.35 mg implant, and other was given sham injection. Improvement is greatest with dexamethasone at day 60, but effectiveness waned off by 6 months. And the greater complications that are cataract formation and increased IOP. Anti-VEGF therapy, it is divided by cruise trial giving monthly intravitreal ranibizumab in dose of 0.3 mg, 0.5 mg, and sham injection. Outcome was measured as change in VCBA at 6 months, and the treatment with ranibizumab is superior to sham injection. Then Galileo and Copernicus trial. According to this, gain in more than 15 letters of VCB at 6 months. In this, the monthly intravitreal aflibercept 2 mg was given and sham injection in other arm. And the treatment result was monthly treatment with aflibercept is superior to sham treatment as compared to sham injection. Then two other studies are CRAVE and LEVO studies. In CRAVE, they compared intravitreal ranibizumab with intravitreal bevacizumab, and both ranibizumab and bevacizumab reduced mean retinal thickness and improved visual acuity. In LEVO trial, they compared ranibizumab versus aflibercept versus bevacizumab, and they found that the visual result may be worse with bevacizumab when compared with other two agents. Treatment for ocular neovascularization are laser photocoagulation. CVOS recommended that pan-retinal photocoagulation be delivered promptly after the development of NVI or NVA, but not prophylactically in eyes with non-ischemic CRVO. And prophylactic PRP is advised only in high-risk cases such as male gender, short duration of CRVO, extensive retinal non-perfusion, extensive retinal hemorrhages, and cases where frequent ophthalmologic follow-up is not possible. Medical therapy for neovascularization are topical anti-glaucoma agent to reduce elevated IOP, topical corticosteroid to reduce helps in reducing exudation by stabilizing tight junction in neovascular tissue and help in reducing inflammation. Surgical intervention for control of IOP if not responding to medical management. Alternative treatment are oral pentoxifylline drug, which is a potent vasodilator which improves retinal circulation, has shown reduction in the mean CMT by about 10% in baseline patient at the 5 month. Then tissue plasminogen activator. It is a local thrombolysis with RTPA either by intravitreal injection or during vitreoretinal surgery by direct injection into occluded vessel, found to be effective. Reduction in size of clot may lead to entire dislodgement of the clot and subsequent recanalization of the vein. However, there may be serious complications like vitreous hemorrhage, increase in macular edema, and systemic toxicity. Then chorioretinal venous anastomosis. Anastomosis between a retinal vein branch and choroidal circulation. Chorioretinal venous anastomosis. It is an anastomosis between a retinal vein branch and choroidal circulation as it allows venous blood flow to flow out from the eye. As we can see in this diagram, black arrow is shown by anastomosis. This may be achieved either by using argon or Nd:YAG laser and delivery directly at the branch retinal vein to rupture the posterior vein wall and Brooks membrane surgically via transretinal venipuncture technique. Vitrectomy can also be performed in cases with non-clearing vitreous hemorrhages. In patient with CRVO, FFA should be done, and CRVO, if CRVO's macular edema is present, then intravitreal anti-VEGF such as aflibercept, ranibizumab, and bevacizumab to be given. In cases with macular edema, we have to observe for NVE, NVD, and NVI. If it is not present, then we'll go for observation. If it is present, then we'll go for panretinal photocoagulation if NVI is present in more than 2 clock hours. Then hemiretinal vein occlusion, also known as hemicentral retinal vein occlusion. When thrombosis occur in one of the trunk, it is labeled as hemicentral retinal vein occlusion. It is the least common type of venous occlusive disease. Pathophysiology, it is thought to have two possible pathomechanisms, which are hemicentral as a variant of CRVO or hemispheric as a variant of VRVO. In hemicentral retinal vein occlusion, it is occur as a variant of CRVO in cases where two trunks are present which are forming the CRVO. And it is present in about 20% of eye, and occlusion occurs within the optic ducts, which but only affect one of the central retinal venous trunk. Then hemispheric central retinal vein occlusions are occlusion of major vein of the major branch of the central retinal vein at the level of disc. Clinical feature: inferior or superior field defect depend on the quadrant involved. Dilatation and tortuosity, flame-shaped hemorrhage, and dot plot hemorrhages are involved in the particular quadrant. Macular edema involved cotton wool spot and splinter hemorrhage in the involved quadrant. FFA shows capillary non-perfusion area in the involved retina. Then branch retinal vein occlusion. It is the most common type of retinal vein occlusion, most commonly seen in the 7th decade with no gender predilection. Seen more frequently in the temporal than the nasal part of retina, and among the temporal superior than the inferior. Pathogenesis: there is a focal occlusion of the central of the retinal vein at AV crossing with artery overcrossing the vein, which causes compression of adjacent vein. Turbulence of blood flow, endothelial cell damage, and thrombotic occlusion of vein causes elevation venous pressure and lead to macular edema and ischemia of the involved quadrant. It is divided into major VRV if affecting one of the 4 major branches of the central retina, or macular VRV involving only macular branch. Clinical feature: sudden painless blurred vision and metamorphosia or a relative field defect in the involved vein and the area drained by it. Visual acuity in BRV is variable and depend on the extent of macular edema. Ocular examination include evaluation of iris and the angle neovascularization. Fundus shows dilatation, tortuosity, flame-shaped hemorrhage, dot and blot hemorrhages in the affected segment. The site of occlusion is often identifiable as an AV crossing point, as in picture A. In this picture, at point A at the disc, at AV crossing is present at the B, then at the macular branch of at the point C. D, E, and F are the peripheral points. Fluorescein angiography shows delayed venous filling and blocked fluorescence due to retinal hemorrhages and staining of vessel wall. Hyperfluorescence due to capillary non-perfusion areas. OCT shows quantification of macular edema and modality for monitoring severity. OCT angiography shows fast enlargement and retinal ischemia with sign of venous congestion in both superficial and deep capillary network. Chronic VRVO. Acute feature resolves within 6 to 12 months after the VRVO and replaced by exudate, venous sheathing, and sclerosis peripheral to the site of obstruction. There will be presence of collateral or shunt vessel. FFA shows delayed filling of occluded vein and capillary non-perfusion area and dilatation of adjacent capillaries, microaneurysm, and collateral vessel formation. Prognosis: at 6 months, about 50% of eye achieve vision of 6 by 12 or better. Macular edema is the most common complication, and neovascularization occurs most commonly in the retina in 60% of eye with more than 5 disc area of non-perfusion. Neovascularization occurs in response to release of VEGF from hypoxic retina 6 to 12 months following VRVO. Then macular VRVO: when one of the tributary vein draining the macula is blocked, there will be thrombosis of one of the branches of either superior or inferior temporal vein draining the macular area. Clinical feature: sudden painless loss of central vision, pupillary reaction will be normal, and the patch of variable size in the macular area with few superficial hemorrhages and one or two cotton wool spots. FFA at this stage may depict area of capillary non-perfusion along with the complete encircling patelloid hyperfluorescence areas of macular edema. Management includes medical therapy, laser therapy, anti-VEGF therapy, intraocular corticosteroid, and surgical management. Medical therapy is essential to identify and treat the risk factor in the consultation in order to treat and to prevent the risk of future RVO in older individuals. Patient under 50 years of age, extensive workup following VRV is often necessary, inclusive investigation for hypercoagulable and hyperviscosity states and to treat these. Laser therapy is required for treating BRV-associated complication of CME and neovascularization leading to vitreous hemorrhage. Recommended is grid macular laser parameter including 100 for 100 millisecond, 100 micrometer diameter spot size and power setting sufficient to produce medium white one. Scatter laser photocoagulation only after the development of neovascularization elsewhere. Applied with green laser to achieve medium white ones of 200 to 500 micron in diameter spaced one width apart, covering the entire area of capillary non-perfusion in the concerned quadrant. According to VWAS, at the one treatment arm was given grid macular laser and observation and found that grid laser improved the vasculature visual acuity. When neovascularization and vitreous hemorrhage present, arm was given scatter peripheral laser and other was observation, and it is found that scatter photocoagulation to the involved sector improved the visual acuity. Intraocular corticosteroid by SCORE study by giving 1 mg IVTA in one arm, 4 mg IVTA in second arm and macular grid laser, and it is found that early visual acuity gains with steroid treatment were not sustained. Therefore, use of IVTA is advised only to those cases where treatment is refractory to other modalities. Then Geneva trial, anti-VEGF therapy like Bravo therapy, Brighter trial, Vibrant trial, and Verwalt study. To summarize the therapy for BRVO, the primary treatment include observation, especially for first 2 to 3 months, followed by detailed evaluation of retinal perfusion and neovascularization. In cases where there is a macular edema and no contraindication, anti-VEGF injection is recommended. Patients not responding to anti-VEGF therapy are given IVTA or steroid implant therapy. If there is still no response, then grid laser photocoagulation is a therapy of choice. For patients with focal leaks on fluorescein angiography, focal laser photocoagulation is done. If the patient has macular edema along with capillary non-perfusion area, then combined therapy of anti-VEGF followed by laser photocoagulation of the capillary non-perfusion region, usually delayed by 2 weeks, is preferred. Combined retinal artery and vein occlusion. Patient with combined CRAO and CRVO generally present with sudden decreased vision. Fundus examination shows superficial retinal whitening with cherry red spot and signs of venous obstruction such as dilated and tortuous veins with intraretinal hemorrhages, optic disc edema, cotton wool spot, and marked thickening of the retina. The combined CRA and CRV has been associated with autoimmune diseases such as Wegener disease, systemic lupus erythematosus, and giant cell arteritis. Compressive or infiltrative disorder of the optic nerve, orbital inflammatory disease, posterior scleritis, optic neuritis, syphilis, trauma, superior ophthalmic vein thrombosis. Combined BRVO and BRAO. It is first of all we have to examine the neovascularization. Gonioscopy was performed to detect the neovascularization of the anterior chamber and the dilated fundal examination. Systemic evaluation, RBS, BP, RFT, lipid profile, serum homocysteine level, and anti-nuclear antibody CNCA and RA factor to be done. ECG and echo was also advised. Pathogenesis. There is a compression of atherosclerotic artery by atriovenous crossing which causes turbulent blood flow which lead to dynamic obstruction or actual thrombosis formation and mechanical blockage. If severe enough, there will be sudden rise in intravascular pressure which lead to back pressure of the arterial circulation and compromise the arterial perfusion which manifests as BRAO. Epidemiology, relatively young predominant man had multiple cardiovascular risk factors such as diabetes, hypertension, and dyslipidemia. Out of 6 cases noted in the literature, 2 patients were in their third decade, one associated with cytomegalovirus retinitis in 26-year-old man with AIDS, and the second case following hepatitis C in a 20-year-old man. And other cases were present in 9-year-old man with hyperhomocysteinemia and combined branch occlusion. Other 3 cases were in the 6th decade, one being a hypertensive man and 2 being women with uncontrolled hypertension, and diabetes. Symptoms are sudden painless sectoral vision with blurring and field effect corresponding to the affected retinal quadrant. Fundus evaluation shows narrowing and cattle tracking in the artery and the dilated vein, tortuous vein in the involved quadrant or hemisphere. There will be retinal whitening or featureless retina and flame-shaped and dot blood hemorrhages. Fundus fluorescein angiography, there will be delay in filling of the involved artery and gross delay in the venous filling along with the area of capillary non-perfusion. Treatment is laser photocoagulation and use of intravitreal bevacizumab and radial optic neurotomy. Take home message, it is retinal vein occlusion are the second most common retinal vascular disorder diseases after diabetic retinopathy. We have to differentiate between ischemic versus non-ischemic CRView to guide prognosis and for follow-up. Macular edema is the main cause of vision loss and the mainstay of treatment is anti-VEGF. OCT and OCT angiogram is essential for diagnosis and monitoring. FFA for ischemia mapping is important. Address systemic risks like hypertension, diabetes mellitus, hyperlipidemia, glaucoma, rule out thrombophilia in young. Watch for neovascularization, may need PRP to prevent NVG. Condition is chronic, so require long-term follow-up and patient counseling is necessary. Thank you.